Well, good morning. Two important observations when you fly in from the future to a conference. One, your luggage gets stuck at the airport. And two, in the future, we don't have gray hair. But I'm sure that I will soon. So, I'm Lauren Hughes. I'm a third-year resident in family medicine at the University of Washington, and it's an honor to speak with you this morning. Today, we have heard from researchers of NAPGRAG's past. I share predictions with you as a researcher of the NAPGRAG yet to come. I have been tasked with the future of primary care, a rather tall order, thank you, Martin. What technologies will innovate how we practice, what systems level changes will impact care delivery, time will soon tell. In addition to advances in technology and care delivery, fascinating therapeutics are on their way. Take, for example, induced pluripotent stem cells that avoid ethical dilemmas of their embryonic companions. These reprogrammed adult stem cells may lead to regeneration of organs and rehabilitation of spinal cord injuries. Next up, novel therapeutics. What if you could genetically know years in advance your predilection for breast cancer? And what if you could take a pill to reduce that risk? And then there are the pills with embedded microchips, recently approved by the FDA, to closely monitor how compliant our patients really are with their medications. Dedicated to manipulating matter at the atomic level, nanotechnology has untold implications for engineering and science. When it comes to medicine, could nanoscale vaccines eradicate HIV? Could nanomagnets cauterize tumors? And could nanosensors detect sepsis before we even know it's happening? And now to the world of innovative technology and mobile health that can be summarized in one phrase. There's an app for that. I predict the use of 24/7 body monitors connected to our smartphones, used to detect vital signs, sleep patterns, glucose monitoring, calories burned, heart rhythms, you name it, it's coming. It's one thing to collect numbers via monitors, but with web-enabled and interconnected electronic medical records and social media, our patients can send us critical data for interpretation. Such an interface holds significant opportunities for expanding the reach of primary care, especially in rural and in global health settings. I foresee primary care transitioning from reacting to preventing in a very personalized manner. Imagine a device that allows a patient to collect a pinprick of blood, make thousands of measurements, and send the analysis to a distant computer. If all is well, the doctor can send an email back saying, we'll see you in 6 months for your next home checkup. Such remote technology may obviate the need for in-person well visits, freeing our time for high acuity visits that still require face-to-face consultation and clinical reasoning. Digitizing, however, will require significant paradigm shifts in how we conduct research and adapt medical education in light of vast amounts of complex data. Virtual visits may also negate the need for face-to-face encounters. Web-based, interactive software platforms allow doctor and patient to discuss prevention and chronic disease. Such approaches could save expense, time, and hassle in today's fast-paced society and allow flexible scheduling options. The Mayo Clinic specializes in collaboration, and now the famous institution is taking collaboration on the virtual road. Mayo is reaching out to physicians in all fields nationwide via remote electronic expert consultation. In a time of health system expansion and consolidation, Mayo yet again is setting new standards. Project ECHO, an initiative of the University of New Mexico, is another innovative strategy transforming primary care delivery in rural, underserved areas. Focusing on common and complex chronic diseases, this effort delivers specialty care to remote regions via electronic collaboration and education. Practice-based research networks are a means to conduct research in busy primary care settings. However, in order to ensure their future success, several things need to happen. Increasing the use of health IT, recruiting and retaining more clinician researchers, and partnering with academic institutions are key. Furthermore, developing clinically relevant research questions and seeking sustainable financial support for PBRNs are crucial. Most importantly, however, is the need to establish consortia of PBRNs that are more effectively able to collaborate, expand, and disseminate their findings. Are we prepared to integrate mental and physical health under the same roof? Not yet. But with enhanced education for primary care providers, increased knowledge of telemedicine, referral, and team care options, and parallel research regarding both primary and mental health workforce shortages, we can be. By co-locating and co-providing both primary and mental health care, we reduce stigma and achieve parity. Our patients, especially our veterans, deserve mental health access that's not down the hall, in the next building over, or across town. Many clinics nationwide, including within my own residency, are struggling how to implement patient-centered medical home principles. Regardless of who leads the medical home, many of our current efforts are inwardly directed. In the future, I envision a greatly expanded medical home within communities. Future medical homes will employ community outreach visits and enhance electronic access. As a result of the more detailed patient registries enabling targeted prevention interventions, medical homes will effectively offer group visits, as well as increased use of innovative technologies that we have discussed today. And lastly, the Primary Care Extension Program, a concept pioneered by our own Dr. Kevin Grumbach and preserved within the ACA. Paralleling the USDA Cooperative Extension Service, this new extension program concept creates a system of state hubs linking federal public health and county-level delivery of primary care. Health extension agents promote relationships with primary care providers, facilitate knowledge transfer, encourage adoption of health IT, and provide feedback regarding practice transformation. In fact, I foresee the Primary Care Extension Service as the ideal mechanism to blend many of my predictions I've offered to you today. The past 40 years have been rich ones for NAPCRG, as well as for the stakeholders who benefit from the high quality and meaningful research our members produce. What will the next 40 years really bring? I look forward to meeting again with you in Ottawa in 2013 as we start researching the next chapter together. Thank you very much, and happy birthday, NAPCRG.